So let's start the lung cancer. Lung cancer is the leading cause of cancer death. Presentation is cough, hemoptysis, bronchial obstruction, or wheezing, and pneumonia. Okay, so coin lesion on the chest X-ray or non-calcified nodule on the CT. So remember, the nodule are generally non-calcified in case of cancer. Sites of metastasis from the lung cancer include liver, adrenal, bone, and brain. Okay, so which is remembered by lab, or also you can refer to my image. You see, it can either fall down into liver or adrenal, or it can go to the bone or brain. Okay, but if they ask you what are the things that can metastasize into the lungs, those are either breast, colon, or bladder and prostate. Okay, so bladder and prostate, or breast and colon. Okay, so you can see over here, uh, mm, in the lung, metastases are more common than the primary neoplasm, most often from the breast, colon, prostate, and bladder cancer. And the features are, mm, remembered by sphere mnemonic. So superior vena cava syndrome, that is, or thoracic outlet syndrome, Pankos tumor, Horner syndrome, endocrine, which is related with the paraneoplastic syndrome, recurrent laryngeal nerve compression leading to hoarseness, and effusion could be pleural or pericardial. So this is very, very important, that you need to know that lung cancer can even cause pericardial effusion, not only the pleural effusion. Okay. Risk factor include smoking, second-hand smoke, radon, which is in mostly in the mines, caves, or basement, asbestos, family history. Squamous and small cell cancer are central and often caused by the smoking. Now let's talk about the different types of cancer. First of all, we'll talk about the small cell or oat cell cancer. It is central and is caused by risk factor is smoking. Undifferentiated, but it is very aggressive, may produce hormones like ACTH, uh, causing Cushing syndrome, SIADH, or antibodies against presynaptic calcium channel, Lambert-Eaton myasthenic syndrome, or neurons leading to paraneoplastic myelitis, encephalitis, or subaqueous cerebellar degeneration. Amplification of MYC oncogene is common, managed with chemotherapy with or without radiation. So it cannot be surgically incised. So that is why we give chemotherapy with or without radiation. Okay, neoplasm of neuroendocrine or Kulczycki cell leads to the small and dark blue cells in the histology. You can see over here a small and dark blue cells over here. You see, so basically this is the small and dark blue cells, all over. So this is the case of small cell cancer. Okay, now getting into the adenocarcinoma is peripheral, remember that, and most common primary lung cancer, more common in women than men, most likely to arise in non-smokers. So basically, small cell carcinoma and squamous cell carcinoma is common in smokers, but this is in the non-smoker. Activating mutation include KRAS, EGFR, and ALK. Associated with hypertrophic osteoarthropathy, that is clubbing, and also dermatomyositis, which is not given here, but remember that adenocarcinoma for ADE and dermatomyositis also DE. Okay, so that is how I remembered adeno and dermatomyositis association. Okay, bronchoalveolar subtype, that is adenocarcinoma in situ. Chest X-ray often shows hazy infiltrate similar to pneumonia, with better prognosis. So these have a better prognosis. Glandular pattern on histology often stains mucin positive. Bronchoalveolar, which comes from the Clara cells subtype, grows along alveolar septa, apparent thickening of the alveolar walls, tall columnar cells containing mucus. Okay, remember this. So there will be in the bronchoalveolar type, you will find that there is apparent thickening of the alveolar walls. Why? Because the alveolar septa are involved, and there is tall columnar cells containing mucus. Now, talking about the squamous cell carcinoma, there is not much thing to know about the squamous cell carcinoma. Just remember that it is more common in smokers and is central. Hilar mass arising from the bronchus, cavitation, and cigarette association, and hypercalcemia produces because of the release of parathyroid hormone related peptide via paraneoplastic syndrome. Okay, so keratin pulse and intercellular breeze, that is very important in this case. And also so now we will talk about the giant cell tumor. Okay, so this is basically the giant cell or large cell carcinoma. So here you can see large cell carcinoma is basically in the peripheral zone, highly anaplastic undifferentiated tumor. uh, so if it does not resemble any of the classic features, then remember it is most probably talking about the large cell cancer in the question stem. Okay, so highly anaplastic undifferentiated tumor, poor prognosis, less responsive to chemotherapy, removed surgically, strong association with smoking, remember that, and also it is associated with gynecomastia and galacturia. So just imagine giant boobs in case of giant cell or large cell tumor. Okay, so gynecomastia, galacturia, and giant cell. Pleomorphic giant cells are present here. Now, last but not the least, bronchial carcinoid tumor. It could be central, it could be peripheral. Excellent prognosis, metastasis is rare, and symptoms due to mass effect or carcinoid syndrome. So it can be anything. Okay, either mass effect or carcinoid syndrome. Carcinoid syndrome, flushing, diarrhea, wheezing, and nest of neuroendocrine cells, chromogranin positive. Now, how will you compare? How will you differentiate between these two? Is via the small cell, small blue cells, but carcinoid will have polygonal cells with eosinophilic cells, right? So here you can see this one is the last one here. uh, this is the adenocarcinoma, and this thing is the adenocarcinoma over here. You see, these are the adenocarcinoma gland formation. And if you see in the image, this is the hilar lymph node of squamous cell carcinoma. This one is the hilar involvement of the by the squamous cell cancer. Okay, and you can see this is the keratin pulse over here. You can see keratin pulse. Okay, intercellular bridge is not seen over here, and in this case you can see the giant cells. Okay, these are the giant cells, big cells. Okay, so giant cells. One thing I want to add is about the hematoma. Hematoma are benign lung tumor that are often detected incidentally on chest X-ray as a peripheral coin lesion. Histological examination shows areas of mature hyaline cartilage mixed with connective tissue, smooth muscle, and fat cells. Pre-invasive lesions such as adenocarcinoma in situ are not benign. Okay, these are not benign pre-invasive lesion, but hematoma is benign, which is composed of mature hyaline cartilage. Also, you can see the popcorn calcification. It is also called popcorn calcification. And this mature hyaline cartilage is mixed with connective tissue and smooth muscle along with fat. Okay. Okay. Next we have lung abscess. Lung abscess is nothing but localized collection of pus within the parenchyma caused by aspiration of oropharyngeal content, especially in patients predisposed to loss of consciousness, example alcoholics and epileptics, or bronchial obstruction, for example in the cancer, right? So air fluid levels often seen on chest X-ray presence suggest cavitation due to anaerobic bacteroids, fusobacterium, or peptostreptococcus or Staph aureus. Treatment is antibiotics, drainage, or surgery. Lung abscess secondary to aspiration is the most often found in the right lung. Location depends on the patient's position during aspiration. Right lower lobe if upright, and right upper lobe or middle lobe if the patient is in the recumbent position during the aspiration. Okay. Now let us talk about the Pancoast tumor. Pancoast tumor, also known as superior sulcus tumor, carcinoma that occurs at the apex of the lung, may cause Pancoast syndrome by invading compressing local structure. Compression of the loco-regional structure may cause area of findings. For example, if the recurrent laryngeal nerve is involved, there will be hoarseness. Stellate ganglion if involved, there will be Horner's syndrome, ipsilateral ptosis, meiosis, and anhydrosis. Superior vena cava syndrome, also the brachiocephalic vein, brachiocephalic syndrome, unilateral symptoms, and brachial plexus leading to the sensory motor deficit. Now remember one thing, that superior vena cava syndrome can occur in the superior sulcus tumor, but it is not that common as Pancoast tumor. I mean to say shoulder pain or Horner syndrome, which are more frequent manifestation. All right. So now we will talk about the superior vena cava syndrome particularly. Okay. So you can see it is an obstruction of the superior vena cava that impairs blood drainage from the head. Note the blanching after the finger press. You see over here, you can see the blanching, right? So this is the blanching. And also you will see there is raised JBP and upper extremities edema, commonly caused by malignancy, example mediastinal mass, Pankos tumor, and thrombosis from the indwelling catheter. Okay, so it can also occur because of the thrombosis due to indwelling catheter. You can see over here there is thrombosis in the superior vena cava. So this thrombus due to indwelling catheter can also trigger the superior vena cava syndrome. Okay, this is a medical emergency, can raise intracranial pressure obviously if obstruction is severe, leading to headache, dizziness, and increased risk of aneurysmal rupture of the intracranial artery. So just imagine this picture, there is raised JVP, headache, risk of aneurysmal rupture of the intracranial arteries, and there can be dizziness. Okay, this is star is for dizziness, and could that can also cause headache. Okay, thank you. And now we will start the pharmacology in the next section.